Hello, I am Dr. Kaushik Mukhopadhyay, and today I am going to discuss about the female reproductive system and hormones controlling that is estrogen and progestins. It will be covered in two sessions. Today I will discuss estrogen, and in the next session I will discuss progestins. So we already know that the estradiol and progesterone is actually made of a steroid ring. So you can see here the estrogen and progesterone both have this steroid cyclopentanopyritophenoxy nucleus, and there are some modifications, additions, and of this nucleus, so that there is different steroid hormones are produced. So we will discuss how the estradiol is produced and how the progesterone is produced. But first, let's discuss about the physiology of the female reproductive system. You know that the female reproductive system, whenever we hear this, the first thing that comes into our mind is the ovary and the uterus and all the associated parts. But the actual thing, it starts in the hypothalamus. So hypothalamus releases gonadotropin releasing hormone, which tells pituitary, the anterior pituitary to be specific, to release hormones like luteinizing hormone or the follicular stimulating hormone. These two hormones takes pivotal role in maintenance of the Graafian follicles and the ovum and the other part of female reproductive cycle. So the reproductive physiology is every cycle we know that one ovum is released from the ovary, it is taken up by the fimbriae just like here, and then it traverses back, and if it meets spermatozoa then it forms the zygote, mostly in the fallopian tube somewhere here, and if the zygote successfully formed, then it goes there and it is embedded in the endometrium initially. And the hormones that takes care of all these things are two hormones mainly, estrogen and progestins. So estrogen and progestins. There are some other hormones like inhibins also, but these are the most two important hormones that controls every part of the cycle. So let's see what are the parts of the cycle. So if you see that everything goes on a cycle of the cycle is mainly for the most of the females it is 28 days, but it may be more than 7 days so and less than 7 days, so 21 to 35. So this is the normal period you can think about. If it is less than 21 days, that one cycle, then it is pathogenic or pathologic, and if it is more than 35 days, then we call it oligomenorrhea, and it is also not normal. So if you consider normal cycle, let's discuss it with this 28 days time frame. So what happens if you see in the ovary, the ovarian cycle starts first a Graafian follicle, actually not one, 10 to 15 follicles starts growing. So it starts growing, but ultimately only one will form the Graafian follicle itself. So initially there is primordial follicle, then primary follicle, then Graafian follicle. I think you all know this from your knowledge of physiology. So this is the changes. So on 10 to 15 follicle starts the journey, but only one makes it. So ovulation occurs only only from one Graafian follicle. Then this Graafian follicle, after the ovulation happens, so you can see in the last diagram, if the ovulation happens, then the Graafian follicle is turned into this corpus luteum. Here, so the corpus luteum. The purpose of all these phases are actually different, and finally after the cycle is over, it becomes corpus albicans. If you see the body temperature, it also varies within 36 to 37 degrees Celsius. So about the time of 14 days, that is about the time of ovulation, the body temperature slightly rises, which then again comes to the 36 degree range at the end of the cycle. If you see the anterior pituitary hormones, the green one is follicle stimulating hormone, this green one. So initially it gradually rises, and after some time it decreases, the concentration is decreased. Now why this happens? Because this follicle stimulating hormone actually it have positive effect on this primary follicle. So from primordial follicle to primary follicle, we do not know the influence of FSH, but from primary follicle to get more mature, we require FSH. So FSH, when the level of FSH as the initial part of the cycle, as it increases, or we can also call it follicular phase, when it increases, it also increase the synthesis of estradiol. Where? From, of course, it is from granulosa cells. Now, when estradiol reaches a level, it inhibits the formation of FSH. So it is like feedback loop. If you go to the last diagram, so there is, you can see here, this estrogen actually inhibits the hypothalamus and also inhibits the pituitary. So that decreased FSH occurs. So that is why ultimately this FSH is decreased. Now the biological effect of this FSH decrease is that only one follicle which has reached the actual Graafian follicle stage is now secreting more and more estrogen so that it can inhibit the release of FSH. So ultimately, if FSH level is decreased, the other follicles, which these 10 to 15 follicles, we started the journey without FSH. When the FSH level is decreased, they cannot make it. So ultimately, they will die. So that will happen. So this is the selectivity of one follicle happens in this stage due to the fall of FSH. Okay, that is all these things are actually part of physiology. So ultimately at this stage, the estrogen, suddenly what happens? The estrogen starts giving positive feedback loop. Why it happens, it is not properly known, but it depends upon the frequency and amplitude of the LH and release from the anterior pituitary. So whatever the reason, the estradiol makes a positive feedback loop, and suddenly there is high amount of LH surge occurs. So this phenomenon is called LH surge, and this LH the increased LH helps the ovulation. So you can see here ovulation is happening. As soon as this ovulation is happening, so until this follicular phase, also what is happening in the uterus, the uteri is getting more and more cells, and also there is formation of these glands and these arteries. These are all under the effect of estrogen. This is happening under the effect of estrogen. After ovulation, there is increased level of progesterone happens. Now the purpose of progesterone is to make endometrium ready for pregnancy. So you can see progesterone as a pro-pregnancy, it is written here. So it makes uterus endometrial, the glands becomes more deep, and the arteries that was here, it becomes tortuous. So you can see it is tortuous. So these are the effects is under the effect of progesterone. So progesterone makes this uterus ready for conception. But if the ovum does not meet the spermatozoa, so what is the time that the ovum is after ovulation it survives? It is only 48 hours. So within 2 days it must be the zygote must be formed, otherwise the ovum will die. So this progesterone makes the uterus ready for pregnancy, but actually the ova dies if there is no spermatozoa. That ova dies at this level, probably in the timeline at this level, if there is no spermatozoa meets the ovum. But then still the progesterone does not know that, and the uterus does not know that. So ultimately the uterus is formed. The uterus, it is becoming more tortuous, it is becoming more, the glands are increasing, but it waits for this amount of period, maybe 12 days. So if we know that after this 2 days, then it is around 12 to 13 days it takes. But after that, it becomes depressed. So now it knows that the spermatozoa has not reached any ovum, so there is no pregnancy this time. So now we have to shed this endometrium. So this is the start of menses. So you can see there is again there is vasoconstriction here. So ultimately the layer above, it is shredded. So it is shredded during the menses, and ultimately a new cycle again begins. A new cycle begins here. So this is in a nutshell how the physiology of female reproductive cycle occurs. And we have to understand the role of estrogen and progesterone in every part of the cycle. So you can see the effect of estrogen is the uterus, the maintenance of menstrual cycle. Just we discussed this. It also maintains the physical shape, breasts, external genitalia, skin texture, and emotion. So if we look at the physical function of estrogen, first go back to this. Let's discuss this. So you can see this is the functions of estrogen. So let me write this. Functions of estrogen. It has functions related to the female characteristics and female genitalia. So this is, you can see the ovary produced from growing eggs. Then uterus, monthly preparation. We already discussed the follicular phase is mainly controlled by estrogen. Vagina, it makes it moist. It protects from infection also. Breast grows and shape the actual female shape of breast appears under the influence of estrogen, and of course prepare breast for feeding. So all these things, this and this, are part of female reproductive system and secondary sexual characters in female. So these are all parts of this. But apart from this, estrogen has some other important actions too. Very important function is development of bone and maintenance of bone. So bone mineral density, maintenance of bone mineral density, especially in female, the estrogen has a very important role. Next, it protects heart from cholesterol. So it decreases LDL level and increases HDL level. So this actually helps in the balance of the lipid profile balance. But one problem is that it increases coagulability because of increased formation of coagulation factor, increased formation of coagulation factors. So by this action, estrogen increases chances of thromboembolism. So this is one problem of estrogen. Second, it reduces cholesterol in blood. This is a good effect, and it has some effect with the mood, emotion, memory function, libido, and of course the body temperature maintenance. All these functions regarding neurological part of brain is controlled by estrogen. Then skin, it makes skin young, and it has some anabolic action. It is not as anabolic as androgens, so anabolic steroid hormone, but it has of course some anabolic action. It causes mild salt restriction, it will be retention. Okay, mild salt retention, and it can cause mild impaired glucose tolerance, but with therapeutic dose these are not very evident. But these are of course the effect of estrogen. Now why this slide is very important, in the next part of this discussion, you will see that many drugs has estrogenic effect, and also it works in some areas as anti-estrogen. So if you remember all these functions, you can easily deduct that which drug should be used in which condition, and also what adverse effect may be caused by that particular drug. So that is why this is very important to understand the functions of different drugs related to estrogen. Now let's discuss how the estrogen is produced. Now we have, in our body, we have three kind of estrogen: estrone, estradiol, and estriol. This is the most potent one. This is most potent estrogen in our body. So you can see, if you see the synthesis from dehydroepiandrosterone, it is converted into androstenedione, and then this androstenedione is converted into testosterone. This enzyme is very important for the formation of estrogen. This aromatase is present in the granulosa cells. So this is present in the granulosa cells. There are some other cells also, like in placenta also it is formed, and other parts of the body. In the periphery also there is aromatase. So it can be the testosterone can be converted into estrogen in the periphery also. So there are abundant aromatase in everywhere in the body. But this granulosa cells, these are main area where estrogen is produced. So estrone and estradiol is formed, and finally both of them are converted into this estriol. And again estriol can be formed with this aromatase enzyme. So what is aromatase? Basically, if you see the structure, this double bond is becoming this. So aromatization. So you can see the same thing, double bond is becoming this ring. Here the double bond is becoming the ring. So for this ring formation, we require this aromatase enzyme. So if we want to inhibit the effect of estrogen, then we can give aromatase inhibitor, and we will discuss aromatase inhibitor in detail in the final part of today's discussion. So let's discuss about the different estrogens and estrogen related drugs. So this is taken from KD Tripathi. So you can see the natural estrogen, estradiol, estrone, and estriol. We just discussed in the last slide. It is the natural estrogens that we have. But we have also the synthetic estrogens. Now, why we require the synthetic ones? Because if you want to supplement estrogen in hormone replacement therapy, you cannot give this directly, because it is quickly metabolized in liver. So you cannot, so fast pass metabolism is very high. So you cannot give these drugs in as oral route. So you have to give the synthetic estrogens that is not metabolized that easily by liver. Among all this tibolone is important, and ethionine estradiol is also important. From the non-steroidal, you can remember this name, diethylstilbestrol. So these are all estrogens. The whole classification of these are all estrogens. And except this, we have some other kind of drugs which can be used as antagonist, pure antagonist of estrogen, or agonist antagonist. That means in few areas it has estrogen agonistic action, in other areas it works as estrogen antagonist. Like this clomiphene citrate is anti-estrogen. The selective estrogen receptor downregulator, or SERD, fulvestrant. Again, it is acting, from the name you can understand, the estrogen receptor downregulator. So it is acting as anti-estrogen. The selective estrogen receptor modulators, these are very important drugs: tamoxifen, toremifene, and raloxifene. This drug, in some areas, it acts as estrogen agonist, and in some areas it acts as antagonist. So that is why it is called, they are called modulators. So modulators. And finally we have aromatase inhibitors, and aromatase inhibitors mean it inhibits aromatase, so estrogen cannot be generated inside the body, in the periphery, or and also in the from the ovary. So these the drugs are letrozole, anastrozole, and exemestane. So these are the drugs that is used in case of, mostly in case of breast CA, because in the function of, when we discuss the function of estrogen, you have to remember that this breast, the positive effect of estrogen on the development of breast also predisposes the chance of breast carcinoma. So estrogen, due to this effect, can cause breast carcinoma. So let me write why all these effects can cause different kind of problem as well as different kind of good things also. So this effect on breast can cause breast carcinoma. The effect on uterus can cause endometrial CA. So again, this is another bad effect. Endometrial CA it can cause. The effect on increased coagulability, it causes increased thromboembolism. So these are the bad effects. So these are the bad effects of estrogen. If we give external estrogen, we will predispose the patient to breast carcinoma, endometrial carcinoma, and thromboembolism. But it has some good effects also. Good effect on what? Mainly bone. So it prevents osteoporosis. That is a very good effect. Vagina, it makes it moist, so we can use it for atrophic vaginitis or senile vaginitis. So, or senile vaginitis. Here we can use it as hormone replacement therapy. A topical we can use. So we will, when we discuss the use of estrogen, we will see. So these are the good effects of estrogen. And of course it has some good effects here with the lipid profile. Now coming to the intracellular mechanism. So all the effects that we discussed, how it happens. As it is a steroid, it has a steroid moiety, so it can easily goes inside the cell. And the estrogen receptor, it is present inside the nucleus. So inside the nucleus, when this estrogen binds with this estrogen receptor, you can see these are the estrogen receptor, they are separate. So as soon as estrogen binds, they undergoes dimerization. So they attach to each other, and they activates these proteins like SRC1, which increases expression of different genes. So this is how estrogen works, and also it can increases the effective. So you can see here increased gene transcription occurs. On the other hand, if you give something like antagonist, like tamoxifen in some areas, then it will bind to another repressor gene, that is mCON. So ultimately histone deacetylase will be activated and that will stabilize the chromatin. So this is the difference of estrogen agonist and estrogen antagonist. So both of them will bind to estrogen receptor, and even the dimerization will occur of the estrogen receptor, but ultimately it will not do the action of estrogen. Now we have two kinds of estrogen receptor, estrogen receptor alpha and beta. In most areas, both of them are present, but estrogen beta is mainly present in the ovary as well as prostate. Prostate in case of male, of course. So prostate in case of male, and ovary in case of female, it is predominantly here beta is there, and here alpha it is present in uterus and all other areas. If you look at the structure, here alpha and here beta is pretty close to each other. They are almost homologous. Then pharmacokinetics of estrogen. Absorption, it is well absorbed orally. So as it is a cholesterol, so the lipid solubility is never a problem for estrogen. So it is absorbed orally, but the problem is it is metabolized. It is quickly metabolized in liver. So you can see here, it is metabolized. So that is why we have to give the synthetic estrogens. Natural estrogen are largely plasma protein bound. So XHBG, so sex hormone binding globulin. So this is mainly the protein, it remains in the protein bound form mainly. And excretion due to the deconjugation in intestines, it undergoes enterohepatic circulation and mainly excreted in urine. So as it is mainly metabolized in the liver and conjugation occurs with glucuronic acid, they are also prone to be affected by the drug that induces or inhibits the metabolism. So if your patient is taking a drug like rifampicin, which increases the metabolism of estrogen, then in those patients you may require to increase the dose of estrogen. So this thing you have to, this drug-drug interactions you need to remember. Then coming to the use of estrogen, most important probably is the contraception. This contraception I will discuss in the next class when I will finish progesterone. So we can discuss the oral contraceptive pill, so combined pill, progesterone only pill. So that is actually we will cover in the next session. But for now you just remember that it is used in contraception. Next, hormone replacement therapy, very important. So there is menopausal symptom. You can see here written menopausal symptom. So whenever the patient, or I should not say patient, whenever a female, if in physiology also, so during menopause, she suffers from a few symptoms, a few medical problems. We can, if we write this, they can suffer from vasomotor disturbances like hot flash, vasomotor like hot flash, and there may be chilly sensation sometime. Pain can happen, so hot flash or pain can happen. So these are all vasomotor disturbances. So these are all symptoms of menopause. These are all menopause symptoms. There may be urogenital atrophy. So as we already discussed, that estrogen makes the vagina moist, so and it prevents the bacteria to grow. So in absence of estrogen, there is always chance of urogenital atrophy, vaginal dryness, vaginal vulval shrinkage. This can also, vaginitis can happen, itching can happen, all these symptoms can happen. Then comes the role of bone metabolism. So osteoporosis can happen. So why we are discussing all this? If we do not understand this, it is difficult to understand why the hormone replacement therapy is required, especially in case of menopausal women. Then there may be some dermatological changes like dryness, thinning. So dermatological changes that will occur throughout the body. And also there are some psychological changes also. So there may be depression, psychiatry related problem. So depression can happen, anxiety can happen, and there is chances of CVS risks are there. So these are all things that can happen after menopause. So if the patient complains of hot flash and other urogenital atrophy and all these problems, you can consider giving estrogen. But the problem of giving estrogen only is that it also promotes, it will not only take care of this symptom, it also promotes the endometrium to grow, which is not required for this menopausal women. So ultimately it can cause dysfunctional uterine bleeding, and also more importantly it can predispose chances of endometrial CA. So whenever you are giving HRT, you should always give progesterone. Always give progesterone along with it. Do not give only estrogen for this purpose if the person has uterus. But if the person has already undergone hysterectomy, then it is not required, because as the uterus is not there, there is no question of endometrial CA. Next, so you can use this for menopausal symptoms and also for osteoporosis. But osteoporosis, the drug of choice is not hormone replacement therapy. The drug of choice is calcium and vitamin D, and of course we have already discussed in our earlier sessions the bisphosphonates. These are mainly preferred in osteoporosis. But yes, of course, this is if the person is suffering from osteoporosis as well as menopausal symptoms, you can consider giving HRT. What are the risks? Severe events can happen because of increased chances of thromboembolism. Breast CA can happen, endometrial CA can happen. So that is why we add progestins. So this was all about HRT. Topical estrogen can be used in case of senile vaginitis, along with antibiotics. Sometimes we give antibiotic also, antibacterial. So along with antibacterial, you can give topical estrogens for senile vaginitis. Then primary hypogonadism, like Turner syndrome. So if a patient is suffering from Turner syndrome or any other kind of primary hypogonadism, so from 12 years to 13 years, from 12 years to age to lifelong, so almost 60 years, you may require to give hormonal replacement therapy, that is estrogen as well as progesterone. And there is some second line use like acne, dysmenorrhea, DUB, CA prostate. So these are all second line use because in acne we generally prefer the tretinoin and minocycline. So this group of drug. Rarely we use estrogen. In case of dysmenorrhea, we mainly use, or DUB, we mainly use progesterones rather than estrogen. But sometimes estrogen may give benefit. So this was all about use. Let's discuss about adverse drug reaction. So we discussed that it can cause hyperglycemia a few slides back. It can increase incidence of breast, vaginal and cervical cancer. Very important. Nausea and breast tenderness can happen. Hyperpigmentation can happen. It can cause migraine headache, especially the patients who are already prone to migraine. So it can increase the chances of migraine headache. And it can cause gallbladder disease like cholestasis, thromboembolism. This is also important. So these two we are mainly concerned about. The cervical CA or the endometrial CA, breast CA and thromboembolism. This is the main two factors that we are usually concerned about when we discuss about estrogen. Now our next drug is clomiphene citrate. So this is an anti-estrogen, and we mainly use for female infertility. Infertility we can use, especially anovulatory. So if the patient does not have ovulation or any problem of ovulation, we give this drug. So it is basically anti-estrogen. How it acts? It binds to the ear and depletes receptor concentration in the hypothalamus and pituitary. So the estrogen negative feedback, it is interrupted. So if it blocks here, so estrogen negative feedback is not there. So the FSH is stimulated. As more and more FSH is growing, it increases the effect of the action of follicle stimulating, Graafian follicle. So more smaller follicles are rescued, and ultimately multiple follicles are developed. So if you go to this slide we discussed, yes, here. So I think you remember the fall of FSH was due to increased level of estrogen. But it is happening due to its inhibitory effect on anterior pituitary and hypothalamus. But with rising estradiol, if we do not limit the effect of FSH, so ultimately FSH will increase like this, and that will promote more and more Graafian follicles to grow. So initially 10 to 15 Graafian follicles, the primary follicle starts the journey, but only one makes it. But with the effect of clomiphene citrate, as the negative inhibition is not there, so FSH will increase. So more and more follicles will get the push, and they will finally cause ovulation. So smaller follicles are rescued, so multiple follicles develop and it can cause ovulation. So multiple ovulation can happen. So that is why we use it in anovulatory for infertility. So it promotes ovulation. So after 6 months of use, but the problem is, as it is anti-estrogen, anti-estrogen effect will not only be here, The effect will also happen in other areas. So with the pituitary and hypothalamus, it induces ovulation, but it has a negative effect on endometrium also. So reduction in glandular density, decreased uterine blood flow, and cervical mucus, change in quantity and quality of mucus also. So the cervical role of cervical mucus is important because the estrogen increases uh, increases the penetration of sperm in the follicular phase, so that more sperm can goes up. But progesterone actually makes the mucus very thick and not penetrable for sperm. As it has an anti-estrogenic effect, so quality and quantity of mucus is also hampered. So you can see the net effect, if you think that it increases ovulation and it causes multiple ovulation, but it has inhibitory effect on uterus as well as the mucus formation. So ultimately the chances of miscarriage is more, and multiple pregnancy is also more, because more and more ovulation, but the uterus is not being prepared. So this is one problem with clomiphene citrate. So we increase miscarriage rate. That is a problem in case chance of miscarriage. That is a problem with clomiphene citrate. But yes, of course, as it induces, and it is the in case of anovulatory cycle, it decreases the anovulatory cycle, and chances of ovulation is increased by 60 to 65%. 60 to 65% increase of ovulation. So of course, this is one of the major drugs that is being used for decades, maybe 3 to 4 decades in the management of infertility. But you have to remember there is a problem of miscarriage also. Our next group of drug, very important, selective estrogen receptor modulators. So from the name you can understand it has some antagonistic action in some areas and agonistic action in other areas. So they are like estrogen in some areas and like anti-estrogen in other areas. Important drugs are tamoxifen, toremifene and raloxifene. So these are the 3 important drugs. So if you see, now that is why I told you that the knowledge of how the drugs are working in different places is very important. If you understand this and remember this, you can yourself understand what may be the good effect and bad effect of all these ACRMs. So if you look at the effect of tamoxifen, so it is antagonist in breast. So what will be the effect? It can be used in breast CA management. So prevention of breast CA, especially after the breast CA surgery, we can give tamoxifen to prevent further development of residual breast CA cells if there is left behind. So especially if you see the breast CA, we have this ER positive or ER negative. So estrogen receptor positive or negative kind of breast CA. So if the patient is mainly estrogen receptor positive, then tamoxifen will work very good because it has anti-estrogenic effect on estrogen receptor. So any ER positive breast CA, it will work. But the problem is it has agonistic activity of uterus also. So it will be increased endometrial CA. Chance of endometrial CA will increase. So decreased chance of breast CA, but increased chance of endometrial CA with tamoxifen therapy. And if you see bone agonist, so it will help, it will decrease osteoporosis. Now if you come to raloxifene, it has inhibitory effect on breast and uterus, both of them. So it will not cause endometrial CA. So now if we go here, so the effect of estrogen on hot flush. On hot flush, estrogen lowers it, tamoxifen increase it. Why? Because in peripheral site, it is antagonistic. So ultimately it will increase the effect of, increase the chances of hot flashes. Then uterine bleeding and endometrial cancer, if we take it both of them, it is chances increased by estrogen as well as tamoxifen because it has agonistic action on uterus. But raloxifene has negative effect on uterus, so it will not do anything like that. So it will not increase uterine bleeding, it will not increase risk of endometrial CA. Next, prevention of postmenopausal bone loss. All of them has very good effect. So all of them has, so here bone, and also the estrogen is of course increase the bone mineral density. So osteoporosis will be inhibited by all of them. Risk of breast CA, estrogen increases, but in the breast both are antagonist. So this is their main action actually. The tamoxifen main use is breast CA prevention. So it decreases breast CA, it also decreases breast CA. And favorable pattern on serum lipids, estrogen has very good effect, and to some extent tamoxifen and raloxifene are also good effect. So from this table you should deduct all this. Then you will understand. If you can yourself deduct this table from this table, then you will know that you have understand the subject properly. Next is fulvestrant. It is selective estrogen receptor down regulator. So basically they are anti-estrogen. So all of their action is like anti-estrogen, and use is of course breast CA, metastatic breast CA rather. We use this in metastatic breast CA. We can use as it is inhibitory to estrogen receptor. So it promotes accelerated ER turnover. It suppresses ER protein levels. So all of them are inhibited by fulvestrant. So that is why it is effective in case of metastatic breast CA. What will be the problem? Adverse effect? Of course, the good effects of estrogen, it will be anti, so it will increase bone loss. There will be decreased chance of ovulation. So all of these things will happen. Finally, we have aromatase inhibitors. So this picture, it is taken from Guyton. So this is a very beautiful illustration of where the aromatase actually works. So you can see aromatase, it is present in the granulosa cell. So I think you remember where is granulosa and where is theca. So let's so here this near this is granulosa cells. So around this, and outside this, let me take another. Outside this cell are theca cells. So outside this, these are theca cells. So the aromatase is present only in granulosa cells, but granulosa cells cannot produce androgens from progesterone. So progesterone, the androgens is mainly produced in the theca cells, then it is transferred back to granulosa cells where it is converted into estrogen by aromatase. And if we can inhibit this, the drugs like letrozole can inhibit this, so ultimately estrogen production will be decreased. And this not only inhibits in this place, throughout the body, wherever estrogen is converted from androgen, the aromatase is required, and there it can inhibit. So ultimately the effects of estrogen will be decreased. Now what will be the use? Of course we will use in case of breast CA. The main use of these aromatase inhibitors is breast CA. Now this table, it is taken from K.T. Tripathi, very neatly represents all the features of tamoxifen as well as the aromatase inhibitors. So these are aromatase inhibitors. So if you go through the table, you see there are some important points in favor of tamoxifen, and there are some points in favor of letrozole or the aromatase inhibitors. The important difference is that it should not be used, the aromatase inhibitor, in premenopausal women, because you are inhibiting the formation of estrogen. So if you do it in premenopausal women, then the cycle will be disturbed and there will be multiple adverse effects. So you cannot use it in premenopausal women. But in tamoxifen, you can use it in premenopausal women because it has, of course, some estrogenic action also along with its anti-estrogenic action. So this is one important point. An advantage of this letrozole that it can be used beyond 5 years. So that is important for aromatase inhibitors. But it is usually limited to 5 years because of increased chance of endometrial CA. Why we do that? Because there is increased chance of endometrial CA, whereas this does not have any that kind of effect. So endometrial CA chance is not there. So it is mentioned in here, no endometrial CA. So you can use it more than 5 years. Beyond 5 years, no problem. You can use this letrozole in tamoxifen failure cases. So it has greater survival advantage also. But one advantage of tamoxifen is that it improves lipid profile. So this is one advantage of tamoxifen. So you may pause the video and go through all the important points of these two. One major disadvantage, as it is anti-estrogen, absolutely anti-estrogen, it accelerates bone loss and predisposes to fractures. So this is a very bad thing for AI, aromatase inhibitors. But where it is, as it is a in bone, it is agonistic action, it does not cause any bone loss. So this is one advantage of tamoxifen. So if you go through this table, you will know both the functions and principles of tamoxifen as well as the aromatase inhibitors. So this was all about the estrogens. So in the next discussion, we will talk about the progestins and the drugs that is used in for contraception. So thank you for your patient listening. I will see you in the next class.